My name is James Love. I work in Washington, D.C. My background's in economics and in finance. I've been working on issues about the pricing and access of drugs since around 1991. I started out working on cancer drugs. I've worked on different kinds of diseases over the years, and I've worked around the world. I've spent a fair amount of time in work in developing countries, but I've also worked in Europe and in the United States as well. And I work with many of the people who have spoken at this panel as well. I mean, before I start talking about your linkage, I just want to give a copy of a bill. This is a bill that someone sent to me. Well, it's dated March 26th. It's pretty recent. For cancer treatment in the United States for breast cancer. This is the invoice price on this chemotherapy treatment regime was $27,140, discounted to $12,826. That works out to, as the slide shows, around $470,000 a year invoiced, but a very favorable $250,000 discount. Can you imagine getting a $250,000 discount on something you buy? That's not normal consumer good. But even then, I just think that when you look at the prices of new cancer drugs, you have to understand that these drugs are not available to everyone. So implicit in a high price like this is a high degree of inequality. Before you can delink the incentives to invest in research and development, which is what I'm going to talk about next, first I think in the short run, because that's going to take a while, in the short run you really have to protect access. And the one message I want to say, and I want to agree with previous speakers on this, is that I think you have to put the compulsory licensing of patents on the table when you negotiate prices. You can't just assume that you have no choice but to deny the patient coverage if there's a dispute in the prices between the government and the company. Instead of using the patient's coverage as the hostage in the negotiation, I think you should put the patent monopoly as the hostage in the negotiation. So if the negotiations, if the parties can't come to an agreement, the government should break the monopoly on the grounds that it's an abuse of the patent monopoly due to an excessive price. I don't think the patients should continue to bear the brunt of failures in a bad business model. So now I'm going to get into the real delinkage talk. So the policy framework for biomedical research and development financing is as follows, just to simplify things. First, and I think everyone understands how this works, government fund research through government agencies, tax-deductible charities, through grants and research projects. Governments also can subsidize R&D, not through direct grants, but in other ways. For example, until end of 2017, since the beginning of the early 1980s, the U.S. government provided a tax credit which subsidized half the cost of qualifying clinical trials on drugs they called orphan drugs. And that is not really a small category. That was about 80% of cancer drugs approved in the last 7 years. And it was 58% of all new drug approvals approved in the United States last year. So that was a deep subsidy of research and development costs. It's been cut back recently, but that's one way you can do it. But the most important method are the incentives we provide to invest. And that's where most of the public spending goes. Because when you buy a drug and you pay 100,000 euros for it, it's not because it costs 100,000 euros to make the drug. It may cost $100 euros to make the drug, not 100,000. You're essentially, what you're buying is a premium for innovation. And you're doing that because there's a monopoly. And how are these monopolies put into effect? Well, there are different ways. I think people know about patents, but there's also a variety of regulatory measures which prevent other companies from competing. There's supplementary protection certificates which extend the term of the patent, orphan drug exclusivity, pediatric exclusivity, test ed exclusivity, all ways to basically make the drug a monopoly, and that is the reward you give somebody that successfully develops a drug. It's our position that the temporary monopoly is not efficient, it's not fair, it's not necessary, and it's not policy coherent. It's not efficient because the monopoly rewards outcomes that match rather than improve outcomes. So if you develop a drug that is as good as an existing drug, you can make a claim to have a reimbursement that's similar to the existing drug. And companies do that, and they invest a lot of money in those kind of projects. And it's rational for the company, but it's sort of crazy for society because you're effectively reducing the reward to the originator by cannibalizing the market, but you're not improving healthcare outcomes. Society doesn't really get an improvement in healthcare outcomes. They invest in wasteful marketing and non-scientific trials and other ways to increase utilization. The companies have hefty discount rates for future profits. So if you have like a patent and then you have a patent extension and you have a very long monopoly, it's very costly in the later years of the monopoly, but it doesn't influence the initial investment by very much because they discount that at a high rate. The term of the monopoly from drug to drug is pretty arbitrary depending on the skill of your patent lawyers or what kind of science was published before your product was patented. It's not really related to the therapeutic value of the product or the investments in the product. There's a variety of rent-seeking actions where the companies that have the monopoly try and influence the system through political and other means or legal actions to game the system, change the rules, or in some ways to extend the monopolies and block competition. Access is rationed, which is not a minor point. You heard all these presentations this morning. It can be rationed in different ways. You can deny coverage. You can limit coverage to a narrow formulary. You can increase co-payments. You can, in some cases, I mean, there's a lot of different ways, but effectively, you have products that are valuable and useful for patients that patients don't have access to because you're charging huge markups on the product to finance the research and development, and that itself is the most important inefficiency. There's also investment in other areas of research like antibiotic drugs, any kind of research that might lead to a reduction in the dose or identification of adverse effects. Open science, those things are not incentivized by the grant of the monopoly. And it's not efficient because you often have observed excess returns. I know that there was several of the drugs that are talked about have returns, they have sales of tens of billions of dollars. The drug my wife took for cancer had just passed $80 billion last year in terms of 80 billion Swiss francs in terms of the total returns. I think that was, I mean, you know, if money grows on trees, fine, give Roche $80 billion for 80 billion Swiss francs for Herceptin, but that's really more than they needed for that particular product. And that's just money that just sucked out of the system. It's not fair because the high prices lead to financial hardships and unequal access. I mentioned that access is restricted to narrow formularies, and patients, sometimes with different doses of the same difference. You know, there's some kind of cancer drugs where it's twice as expensive for one kind of cancer as it is for another cancer, just based on the amount of the drug that they take. It's not necessary because companies will respond to market entry rewards or other cash rewards to engage in research, such as the open source, or other cash rewards, such as the open source dividend or upstream innovation inducement prizes. And these market entry rewards, which I'm going to talk about, can be de-linked from the prices of the monopolies or products and services. And it's not policy coherent because innovation depends on high prices in the current system, but fairness depends on low prices. So you have a trade-off between innovation and fairness. And any compromise between innovation and fairness leads to a bad place. You shouldn't have to make those kind of compromises. I mean, if you think about it, what kind of a policy would make you give up on innovation because you want to have more fairness, or give up on fairness because you want more innovation? I mean, I shouldn't say what kind of policy, you know what kind of policy, but why would you do that if you didn't have to do it? How do market entry rewards work? Well, the modern approach, which has evolved in the last 15 years, is that the notion that you create a fund of money. Where does the money come from? The money would come from the same people that provide coverage for drugs. Private insurance, government insurance, employer plans, the third-party payers that now are the payers that you expect and when the system is working well to reimburse drugs. So there's money already in the system, so it's not looking for new money. You take the money that you're now spending on high-priced drugs and you put money into these innovation funds. Then you allow any new drug, vaccine, cell or gene therapy, other covered therapy or diagnostic, as well as anything that comes along later that modifies and improves the therapies, to qualify for payouts. I really got to summarize here because of my time, so I'm going to leave a lot of details out, but I can come back if you have questions. And then, because you don't know right away if a drug is very good, you actually, they're designed so you have annual payouts for a period of somewhere between 5 and 10 years, depending on how you structure it. Every year, everyone that qualifies submits evidence that their products or their innovations are used and have a beneficial health effect. And they're competing against everyone else that makes similar requests. So your competitor, so Pfizer would be competing against Johnson & Johnson, and everyone would be competing against Roche. And the more money you gave to Merck, the less money that would be available to the other companies. So the companies are essentially trying to get shares of a pie of a fixed size. So it really becomes a competitive model for making payouts, driven by the evidence of whether the drugs work, benchmarked against existing treatments with some nuances to optimize the incentives and to ensure there are investments in rare diseases. I think at this point, in these conversations have been going on for a while. First, people seem to kind of reluctant to think that you could somehow use money to incentivize a company because they thought there was something magical about the patent system, that the grant of the monopoly had some kind of cosmic, sort of out of this world benefits that somehow, like writing a check, wouldn't have as an incentive. And sometimes it's really a matter of price. I was in a discussion once about a prize for an inducement prize for a new diagnostic test for tuberculosis. And the companies were all saying, we'll never give up our intellectual property. We'll never accept a cash reward for developing a new diagnostic. It's just completely out of the question. And so I said, well, that can't be right. You guys buy and sell your entire company to people for money, right? I mean, what are you talking about? So then I said, would $100 million do it for a TB diagnostic price? And they all said immediately, yeah, $100 million. So I think they thought we were talking about maybe $100 or something like that, So I think that in thinking about how you do it, the first thing you got to remember is you're already spending quite a bit. I mean, the pharmaceutical market's over $1 trillion, I guess. And so there's a lot of money already in the system. You're essentially reprogramming the money from paying paying a really high price on drugs that only a small number of people get, to another way to think about it is just think of this thought exercise. And I'll use the U.S. as an example, but I should use the Irish one, but I don't know the numbers here. In the U.S., maybe last year they spent like $350 billion on drugs, roughly, or maybe 330, something like that. Suppose you wrote a check to the pharmaceutical industry, it was like one entity. It was for the exact same amount we spend for all the drugs, and we said, here, this is what you would have got if you sold us the drugs, but we'll just make them ourselves, and then everybody can get every drug if they need them. I mean, right now, we're paying like $300 billion per year in the United States, and we have rationing, and we have people that are completely stressed out financially, that are just ruined financially. We have all this unfairness. We pay billions of dollars for drugs for Hep C, but we have people that are infected that can't get the treatment. We're treating less than half the people that need antiretroviral drugs for HIV. So the idea is to make it so that drugs are so cheap that everyone that gets the drugs, everyone who needs the drugs, gets the drugs. And you only do that if you allow the prices to fall to the point where the only person involved in the decision about whether you get a drug is the patient and the doctor, not some third-party insurance company that has to do some like incredibly complicated pharmacoeconomic analysis to justify whether it's a reimbursement or not. The problem we've had in the delinkage discussion with people, once they sort of get their head around the idea that you can actually wave money in front of companies, or you can design it in such a way that it would work, using the same data used for reimbursements, and with very minimal change in terms of how you think about or measure benefits, is that they don't think you can go from where we are today to a new system. They think you're kind of stuck. They think, yeah, in like a great world, in a different world, if we would have started out knowing in advance, we would be like literally killing parts of your population over this stupid business model. We would have done something different, but we're stuck because everyone's got all these patents, there's all these investors have made all these decisions, there's billions of dollars in capitalizing the market, so how are we going to ever change? So we've come to the conclusion that really focusing on the transition strategy is quite important. So I'm going to just go through what I think right now is the leading candidate for transition, and then mention 2 other alternatives. So the leading idea for transition right now is that you, in 1 year, you decide, okay, we're going to make the transition to delinkage. And so you say, we're going to cap the exclusive rights on drugs at 15 years, which is a long time, actually. In fact, longer than most drugs actually enjoy. But there are some drugs that actually have exclusivity longer than 15 years. But you say for everything past 15 years, we just issue compulsory licenses on patents or whatever it takes. And it becomes a generic after that. But we know that's going to have a negative effect on innovation. So we're going to introduce market entry rewards, but they don't have to be very big in year 15 because we're not making that big of a difference in the market, just to hold innovation constant. Year 2, you cap exclusive rights in 14 years, but you have bigger, larger market entry rewards. Year 3, you cap exclusive rights at 13 years, but you introduce progressively larger market entry rewards to the point where in year 15 years from now, you have completely wiped out the idea that you even need to have a monopoly, and you're relying entirely on market entry rewards. And during that period of time, the governments have time to learn how to administer market entry rewards, to change their mind if they think the system's going badly. And capital markets have plenty of time to adjust to new systems. Among the other approaches is that you have progressively shrinking prices. So you just impose price controls and you just ratchet down the prices progressively at the same time that you increasingly ratchet up the market entry rewards or other subsidies such as clinical trial costs and things. And another strategy that's been bandied around is the idea that you just buy out the companies. Like in Hep C, several people suggested you could just buy Gilead, take all the drugs that you wanted out of it and put it back in the market. It would be cheaper than buying the drugs from Gilead over time. It's a respectable argument, but a lot of people are kind of maybe not quite sure what they think about it. I think the other strategies, particularly the first one, I think may appeal to these people. I'm not going to talk about these in a lot of time, but there's also proposals that can do a lot more to push the movement of the science upstream, including this idea of an open source dividend and competitive immunities for earlier upstream rewards. I'm going to close with a couple things. One is the European Patent Convention provides an exception to patentability for methods for the treatment of human by surgery or therapy and diagnostic methods. But they say it shouldn't apply to products. And so how is this used? Well, for example, organ transplants are protected by this exception. And there are other things, as long as there's some part of the medical procedure involves some component that's in the body. Where this may be relevant is in the area of some of the new gene and cell therapies. The companies are really describing these things often as drugs, but they're not really drugs, they're medical procedures. CAR T is where you take your blood, isolate your T cells, which are part of your immune system, modify them with a virus, multiply them using rather standard equipment, and then re-inject them in your body. So the only way CAR T is a product is if your blood is someone else's patented product. That said, the European Commission has a directive which sort of makes this problematic, but nonetheless there's a pushback by some countries. And there's a lot of other areas, and the pricing for these new therapies are really, really expensive. What's amazing about these is that sometimes the health benefits are just astonishing. Like Lectura can actually restore sight to people who are blind. The CAR T treatments can take someone who's a stage 4 death row cancer patient and give them a pardon and actually make them like they're essentially cancer-free. It's a much bigger healthcare improvement than a lot of drugs can do. The prices are ridiculous. The first CAR T approved in the United States was developed at the University of Pennsylvania. The cost of manufacturing the cells 5 years ago at the University of Pennsylvania was $15,000. The introductory price by Novartis for the cells in the United States was $475,000. So we asked, if the University of Pennsylvania could do it for $15,000 on a government grant, why does it cost Novartis $475,000? And they said, well, we have a higher degree of clinical quality for the cells. But I think you can, question that. And then they claim they spent $1 billion in R&D, but they only had 63 patients in the clinical trials. We said, well, what did the billion go for? And unfortunately, they weren't very transparent. What are the challenges? Well, one of the main challenges is the timekeeper giving me some signals right here? But show me what you're looking at. I still have time. I'm not over time yet. That's really great. One of the problems, suppose you were to get rid of the patent system tomorrow, or not so much get rid of the patent system, but get rid of the monopolies tomorrow. Could you find suppliers for hundreds of drugs that are used in the treatment of cancer and many more drugs for other diseases? And the answer, if you're Ireland by yourself, I would say no, not for everything, that's for sure. And it would be hard even for some drugs. So one of the ideas people have is that you'd have to go with a club. There'd have to be a group of like-minded countries. It wouldn't have to be 28 members of the European Union reaching a consensus. You don't need that. But you might want to be Ireland plus some other countries which collectively had a big enough market that people would reverse engineer biologic drugs, drugs for rare diseases, all the things that were covered by a delinkage strategy. The EU directives and WTO rules are, in my opinion, manageable. The patent situation, I won't get into the legal details, but those I think are manageable. There's some commission directives which could be problematic. What's the next step? I think the most important next step is for governments to do feasibility studies. Right now, I think Dermot in the previous panel said you have this TINA problem. You don't think that there's any alternative. So if you don't think there's any alternative, you're just sort of stuck with the monopoly. The first step is to get people to realize you can issue a compulsory license on a monopoly. But I think more important than that, which is kind of a limited ambition, you can only go so far by not dealing with the R&D question, is to understand that the whole system could be changed in the same way telecommunications was changed. It used to be that the large fixed cost network for telecommunications was paid by high phone call fees when you called someone on the telephone or when you tried to send a message, because they had a very expensive network and they recovered the cost by charging you to use the network. Nowadays, it's different. A lot of the fees are just to have access to the network. You pay a fixed monthly fee, but then you can really look at as many web pages, read as many emails, surf as many pages, and you can really make as many phone calls as you really want to for the same price. With drugs, it's kind of a similar situation. Thank you for that. The first copy of a drug, the first version, is really, really expensive. The second version is not very expensive. So you have a system where even though you can reproduce a new cancer drug, a therapy for a whole year's treatment for $100, you're going to charge somebody 100,000 euros or more, because that's your brilliant way to finance innovation, which is absolutely a horrible effect on the patients, and it's actually a horrible effect on the entire healthcare budget. There could be a change in the business model, but a feasibility study would look at the soft spots. And one of the things you'd look at is the cost of not implementing it. If you think the system's expensive today, well, it wasn't so bad 5 years ago. What do you think is going to be 5 years from now or 10 years from now? It's just getting worse. And then, so if you don't make a reform, particularly with all these new therapies, targeted therapies, and really exciting advances in science, and the more aggressive nature they have of evaluating these things. So these feasibility studies should also look at what is the access under delinkage and compare it to the access under the current system. What's the cost of achieving the innovation objectives under delinkage? We, in all of our work on it, suggest it's far cheaper to stimulate innovation through a system of well-designed cash prizes than it is through the current thing, which is almost throwing money randomly at companies without any really regard to what their investments are, in a lot of cases what the value of the products are. And what would it be effects on employment? Because I understand people in Ireland think, like, even if you could fix the system, it would be great, you wouldn't want to do it because there are a few thousand people that have jobs in a couple of key areas of Ireland, and it might be kind of traumatic for the people because maybe these big brand name companies are the ones who are impressed with might pick up and leave to another tax agent somewhere else. So, but just imagine that you were become like a complete reversal in the IP policy, and you were not exactly Pirate Bay, but you were like a place where, like really there was no barriers to coming in here and providing CAR T therapy if you knew how to do it, you wouldn't have to worry about the patents. You might pay something to the innovators, but you had the freedom to operate, and you could compete if you could provide a service. And this would become maybe a regional center for providing cell manufacturing and treatments for that treatment, or manufacturing biosimilar drugs, or small molecules, or things like that. Those are things that also involve jobs, as well as the research that you could actually fund as part of your expanded program on government grants and things like that, but be funding people in Ireland. That's the end of my presentation. These are some links for some additional information. Thank you very much.